Here we have a female patient aged 45 with an irreparable carious lesion in the left mandibular first molar number 36. The treatment indicated was extraction and insertion of an alloplastic graft using RTR material from the Septodont company to prevent collapse in the alveolar ridge after extraction and also closure of the wound with the gingival graft inside. We will see this in detail in the description. Here we see the initial clinical condition, a deep cavity and ill-suited restoration, which is already in an unusual condition in the marginal tissues. And the X-ray image confirms the clinical findings. Caries. Treatment of the root canal was apparently well carried out. However, the tooth is no longer restored. On removing the filling, we can observe the occlusal clinical image that confirms the diagnosis of the loss of this tooth due to the lack of adequate restoration. In this image, we can observe the loss of over 80% of the vestibular surface. In almost all patients, the vestibular surface has very specific characteristics, with biological characteristics and/or specific formation, making this the most common in a range of situations. In this case, the lesion has destroyed the area and the work had to be carried out very carefully to preserve as much tissue as possible. If we had handled this lesion surgically, there would have been huge collapse in this area, which would have complicated any type of restoration, whether concerning dental implants or a conventional prosthesis. It is worth noting that the mesial, lingual, and distal walls are almost intact. In this second image, we can see the lesion and how it extends from the occlusal view and the characteristics of the vestibular plate. We can principally observe how this vestibular bone area is not even a millimeter in depth and is lacking thickness. On assessing the post-extraction wound healing biology, we realize that it is almost certain that this bone plate will be lost. Here, we see the first RTR tricalcium phosphate cone positioned in the alveus of the mesial root. We remove it from its packaging by cutting the plastic bag and taking it out delicately with tweezers. Because obviously the material only has a small cover of collagen, we place it directly in the alveolus, in this case the area where the lesion is biggest, which is the alveolus of the mesial root. A second cone is placed in the site. To clarify, the first cone is placed in the mesial root. The material is packed in, but the size of the lesion requires the use of a second cone to bring the material to the most coronal part, as our main goal is to avoid collapse during healing of this site. Without the primary closure, we can observe the first sutures on the lesion. Without this primary closure, without a graft of course, the healing of this site would be even more complicated with a graft at this time of surgery. The patient's agreement is required after explaining the causes. We take a connective tissue graft from the palate, which will simply and easily constitute a membrane to cover this alveolus that cannot be closed for first-line therapy. In this way, we are assured of the most suitable healing possible for prosthetic or implant purposes. We also prevent collapse in this area, which would complicate the treatment or replacement of the tooth. In this X-ray image, we can observe the site immediately after the procedure. As we can see, the tricalcium phosphate granules completely fill the post-extraction alveolus. We can see the cortical areas of this bone. We could still call the alveolar bone itself fascicle bone that has not been reabsorbed. We can also see that the alveolus is completely filled with material. This surgical procedure was carried out in my clinic by one of the postgraduate periodontic students at the Universidad Autónoma de Guadalajara, Dr. Carolina Céspedes, who is under my supervision at the university. In this X-ray we have an approximate date, which we take to be the 16th of October, just a few days ago. We can observe, and this is something to be clarified, that the tricalcium phosphate constitutes an osteoconductive material that facilitates healing and which is replaced over time. It is reabsorbed either via dilution or macrophages. It is diluted and replaced by the patient's new bone. Just 2 months later, we can see a little more. At 2.5 months, we can still see some remnants of material in the bottom of the alveolus. And here it appears that the material is disappearing. We believe, and we will see evidence further on, that it does not disappear. It is being replaced, and yet it is still early for healing. In due course, this patient will be a candidate for the implant department of the school to assess implant possibilities. However, even though the restoration involved a fixed prosthesis, which would be the most advisable, now that this restoration and the other restoration of the teeth, mesial and distal, are no longer suitable, a conventional fixed prosthesis could be an excellent treatment decision for this patient. It would be worth the cost, time, etc.